Hi guys, I'm back in clinic. Everything's firing on all cylinders. I'm aware I've not done an informative post for a while, the odd static, but I thought it's a good idea to review maybe some of the things that I've been seeing over the last couple of weeks. Things that are missed by many therapists, as well as the things that we do and the misconceptions we have with certain things. So I suppose the question I have for you is, how many of you have got or have had ongoing calf problems? That calf complaint that just keeps on going when you run, you keep having to take time off your training, and you're 6 months down the line and you're thinking this should have been better by now. So very, very common. And the biggest factor for this is having a clean diagnosis and knowing exactly what muscle is at fault for the problem, if it is a muscle, and also differentiating other factors like your back, like anything neural, all things that can cause non-specific calf or even foot or heel pain. So I've just had a lady recently, thought she had plantar fasciitis, has had like 6 sessions, no difference. Now the benefit of seeing me is I can do ultrasound scanning. So we scan the plantar fascia, look completely normal. And so that led me to go, right, we need to look at your spine. And after a couple of sessions, she's 80% better. The annoying thing for her is that she spent money having 6 sessions elsewhere. Where actually, if they're a little bit more receptive to her response to treatment, they may have looked a little bit quicker, a bit higher up. So today we're going to look at the calf. And the big question is, how many muscles in your calf complex? So that is the back of the lower leg. How many muscles do you think there are? The big answer is there's about 11. So we're going to have a little look at what muscles there are, and we're going to have a look at how we identify which of these could be the problem. It's difficult for yourself to do it, but as a clinician it should be relatively easy to differentiate through certain testing. Sometimes there isn't a clean yes, it's just that one. There may sometimes be an interface that involves 1, 2 or even 3. Again, if we scan it, there's no argument. We know where it is, we know if there's a lesion in the muscle, we know the rough grade, and then we know how to appropriately treat and manage it. So let me take you over to the calf muscle. So this is the calf, and this is just a diagrammatic impression of what it looks like. Obviously, when we cut someone open, things don't look as clean, as nice as this. There's lots of fascial tissue overriding a lot of these, and how it intercepts through muscles as well. But typically the main two, well, the bigger 2 muscles are your gastrocnemius and your soleus. So your gastroc is this dual-headed muscle that then forms this aponeurosis, which is the Achilles tendon. And then deeper to that, you have your soleus muscle, which, we were always taught this was a postural muscle, but actually, this is one of the biggest causes of calf pain in runners, having weak soleus, because it does that isolated ankle push that the gastroc doesn't do. And strengthening this can be a massive part of getting someone better, or even just improving their running economics. So if we peel away those 2 muscles, this doesn't show it that well, but we have a number of other foot flexors, extensors that all sit beneath there and that attach at varying points around the shin. So deep in here, we've got your perineals, we've got your perineals that run at the side of your leg and deep to here. So these control ankle stability. They assist with push off. And also peroneus longus attaches to the base of your first metatarsal, up in here. So on push off through the big toe, people can get lateral ankle pain, which confuses people. Now the other main ones we see with shin pain and things are tibialis posterior, runs through the inside, okay, and attaches up here somewhere. And we also have, again, another one that is missed by a lot of people is your flexor hallucis, okay, which typically pushes through the big toe, but also extends through the ankle. So there's your flexor hallucis here, that one with the little white band through the middle. So that sits right in front of your Achilles tendon. And sometimes people think they've just got an Achilles problem. And it comes up and it attaches deep in the calf belly. So again, we can palpate it, we can wiggle the toe as we're doing it. Does it produce your pain? And there's a few others as well, extensor digitorum, you know, some of the other perineals that some people have, some people don't, like peroneus tertius. Doesn't always have that on some people. So that is your calf. Now, more importantly, how do we differentiate between which of those muscles is the issue? Our subjective examination is a huge part of that. That really leads us straight away. Most of us know before we put our hands on someone what we think is going on or what we know is going on. And what we're looking for is that diagnostic screening to prove our hypothesis about the functional deficit that we've got. So if someone can't do a heel raise, again, it doesn't tell you which muscle. It could be your calf, it could be, if I say calf, gastroc. It could be soleus, it could be your flexor hallucis. It could be perineals. So it doesn't really tell you a great deal, but what we can do is we can isolate and we can use palpation skills and isolated resisted movement patterns to look at what's going on. So once we've found the issue, what is the next stage? Well, the next stage is to look at where are you along the injury timeline. Is this an acute injury, so a sudden onset a week ago, or is this something that you've had for months that isn't getting better, that we would typically classify as chronic or an overuse injury? When we talk overuse, which can be, you know, flung around left, right and centre, really all that is your ability to cope with load. So your load capacity. So if the stress that you're putting through your tissues or your joints is greater than your ability to cope with it, over time you will get breakdown and ultimately you'll get pain and dysfunction. So once we've looked at that time scale, we then look at, right, have we got healing to take place, and do we want to facilitate that with soft tissue skills, normalizing scar tissue? Ultimately, when we push on those muscles that are sore, you know, they're pretty uncomfortable, but that needs to be graded. You know, it isn't crack an egg with a hammer. The old thing of, for me personally, of deep tissue massage, really, unless you're, you know, a pro with soft tissue in terms of receiving it and you've got really good elastic tissue, then the more you batter someone, the more you're just going to bruise them. And if we did that on Olympic Games or Commonwealth Games, I mean, you'd be thrown off. So deep tissue is a bit of a buzzword that some people like, oh, I'm going for a deep tissue massage. You know, it doesn't matter. It's all about depth that is relevant for the symptom and for the adaptation that you're trying to cause. Yes, 12 hours, 24 hours of a little bit of tenderness is fine, but we don't want to be bruising people. I've had people come in with black marks down the leg where they've had someone get their elbow in there, and I just think really that's not appropriate, and it is a sign that someone's really not feeling what's going on or even understands what's going on. So we've looked at that, and once we're kind of, you know, 4 or 5 days, then, you know, we might want to start loading that tissue, whether that's eccentric or whether that's statically, and that will be guided by where you are in your recovery. Now, if it's a chronic overuse injury, that's a completely different ball, because it may be actually we just need to calm the symptoms first, make it less reactive, and then get you straight into loading. So we improve your capacity to absorb force and inevitably reduce that tissue breakdown. So my next video, we're going to have a look, and I've done it in the past, about how can we take someone through a process of, I say calf, but really limb loading, because, you know, your quad will affect how much you load your calf. And I think there's a relationship between quad weakness and Achilles problems. So I always add in some quadricep functional loading with Achilles rehab. If your quad's weak, you're going to bend your knee more, you're going to dorsiflex more, you're going to load your Achilles more, blah, blah, blah. So we'll go through that process over the next video. We're going to look at static loading. We're going to look at eccentric, concentric, which is where you do it with contraction or whether you do it under a lengthening process. And then we'll look at more functional goals. You know, function is key when you strengthen. It has to be in a functional pattern. So that may be getting someone hopping on the spot first, big hop, little hop, that may be hopping over an object, or that may be doing repeated hops in a straight line. And that could be double leg, single leg. So the progressions can be quite extensive, and you might not be in a single phase for very long. So if you've had a calf problem, it's not getting better, drop me a comment. Let me know how it is, how long you've had it for, how many different therapists you've seen. It'll be interesting to know what's out there. And in the next kind of week, I'm going to go into a bit more of the gym environment, and we're going to look at the progressions that we could do. Obviously, they are always under the guidance of a qualified physio, rather than self-regulating if you're not really clued up. So let's catch up in another 5 to 7 days. Keep an eye on things, and hopefully we'll abolish all of your calf complaints. Have a great day.